Today we'll be talking about the cardiac cycle, part 2. From the first cardiac cycle video, we talked about systemic versus pulmonary circulation, pressures in the heart and heart valves, blood circulation through the heart, the electrical conduction system of the heart, remember this was the wiring of the heart, and electrocardiograms, or EKGs. Now it is time to put this all together in one graph, called the cardiac cycle. Remember, this graph is only reflecting the left side of the heart. The left side of the heart and the right side of the heart pump the same amount of blood, but at different pressures. The left side of the heart is a high pressure system reaching about 120 millimeters of mercury of pressure because it has to pump blood from the heart all the way down to the feet and back up. The right side of the heart is a low pressure system that reaches anywhere between 40 to 45 millimeters of mercury of pressure because it only has to pump from the heart to the lungs and back to the heart again. Now looking at this graph, there are many points where we can start, but I like to start with EKGs. Remember, the heart does not contract or relax to generate pressure to push blood around the body without an electrical impulse. Now looking at the EKG right here, what wave does this look like? This is the QRS complex. And what does the QRS complex represent? Atrial contraction, atrial depolarization, ventricular contraction, or ventricular depolarization? The answer is D, ventricular depolarization. Remember, ventricular depolarization does not mean ventricular contraction. It is just the signal being sent to tell the ventricles to contract. Now that we have sent the signal to tell the ventricles to contract, the ventricles will do just that. They're going to contract. Now referring back to Boyle's law, if the ventricles are contracting, decreasing volume, what will happen to ventricular pressure? Ventricular pressure will increase. See here, ventricular pressure is rising because the ventricular muscles are contracting, decreasing volume, and the reason they are contracting is because the muscles receive that electrical impulse from the electrical conduction system manifested by the QRS complex. They were told to do so. So what happens though when ventricular pressure is greater than atrial pressure? The mitral valve and the tricuspid valve close. Remember, on the cardiac cycle, it only has the mitral valve labeled here because the mitral valve is on the left side of the heart and the tricuspid valve is on the right side. And the cardiac cycle only represents the left side of the heart. If we can remember from the previous video, what opens and closes valves? Pressure. As we can see here, this blue line is ventricular pressure and it is above the black line, atrial pressure. This means that ventricular pressure is greater than atrial pressure. As the ventricles are contracting, increasing pressure, blood is trying to go back through the tricuspid and bicuspid valve. It is important to note that the bicuspid valve is also known as the mitral valve, left atrioventricular valve, or left AV valve, which is short for atrioventricular. Papillary muscles prevent these valves from allowing blood to flow back into the atriums from the ventricles. So as pressure continues to rise in the ventricles, they will eventually open the pulmonary and aortic semilunar valves. Notice here on the cardiac cycle that the low aortic pressure is 80 millimeters of mercury of pressure. In order to open the aortic valve, the ventricles have to generate more than 80 millimeters of mercury of pressure to open it. During this small segment, the ventricles have generated more pressure than the atriums, so the mitral and tricuspid valves are closed. But the ventricles have yet to generate more pressure than the aorta. We call this segment isovolumic contraction. The ventricles are contracting, but no valves are open. Isovolumic, meaning the ventricular volume of blood is the same because no valves are open for blood to go anywhere. Now it's time to summarize what is happening during isovolumic contraction. The QRS complex is the signal that was sent to tell the ventricles to contract. The ventricles will begin to contract, increasing ventricular pressure to be greater than atrial pressure. This will close the mitral and tricuspid valve. Ventricular pressure is increasing, but is not high enough yet to open the aortic valve. No valves are open during isovolumic contraction. And since no valves are open, the volume of blood in the ventricles stays the same, because no valves are open. The next segment of the cardiac cycle is called ejection. Ejection begins when the aortic valve opens. When the aortic valve is open, blood is ejected out of the left ventricle through the aortic semilunar valve into the aorta to enter systemic circulation. Notice here on the cardiac cycle that when ventricular pressure is greater than aortic pressure, the blue line, ventricular pressure, is above the black line, aortic pressure, this will cause the aortic valve to open. Remember, pressure opens and closes valves. As blood is being ejected out of the heart, the volume of blood in the left ventricle decreases. We can see that here on the cardiac cycle as ventricular blood volume decreases. Lastly, notice here on the EKG that we see a wave occur during the period of ejection. What wave comes after the QRS complex? The T wave. And the T wave represents ventricular repolarization. Remember, ventricular repolarization is the electrical signal being sent to tell the ventricles to relax. It is not the actual ventricular muscle relaxing. Now these two segments, isovolumic contraction and ejection, combine together for a period called systole. Systole is used to mean the period in which the heart is contracting to eject blood. Although no blood is being ejected during isovolumic contraction, the ventricles are contracting that lead to ejection. Now we enter into the next segment of the cardiac cycle called diastole. Diastole is the period in which we fill the ventricles up with blood in preparation for another period of ejection. Diastole is broken up into a couple other segments that describe specifically what the heart is doing during diastole. The first segment that we enter is called isovolumic relaxation. Remember, what began isovolumic contraction? The QRS complex, because the heart does not contract or relax without an electrical impulse telling the heart muscle to do so. What was the last EKG wave we left off with? The T wave, right? Meaning ventricular repolarization, which will lead to the relaxing of the ventricles, hence isovolumic relaxation, because we told the ventricles to relax. Remembering Boyle's law, if the ventricles begin to relax, increasing in volume, what will happen to ventricular pressure? The pressure will decrease. Notice the blue line representing ventricular pressure begins to decrease. Isovolumic relaxation begins with the closing of the aortic valve. Remember, pressure opens and closes valves. Where would pressure have to be highest in order to close the aortic valve? Well, in order to open that valve for ejection purposes, pressure had to be greater in the ventricles than in the aorta. That means in order to close the aortic valve, pressure has to be greater in the aorta than in the ventricles. Here on the cardiac cycle, we can see the black line, aortic pressure, is above the blue line, ventricular pressure, meaning that the aortic valve will close. Isovolumic relaxation, just like isovolumic contraction, has no valves open during this segment of the cardiac cycle. As we can see here, ventricular pressure is dropping and is less than aortic pressure, closing that aortic valve, but it's still greater than atrial pressure, which will keep the mitral and tricuspid valves closed. And isovolumic, meaning the amount of blood in the ventricles, is going to stay the same because no valves are open. The next segment on the cardiac cycle is rapid inflow. Rapid inflow is just one part of diastole. The whole segment of diastole is responsible for filling the ventricles with blood in preparation for another period of systole. Rapid inflow begins when the mitral valve opens. Remember, pressure opens and closes valves. So where does pressure have to be highest in order to open the mitral and tricuspid valve? Pressure has to be higher in the atriums of the heart than in the ventricles. We can see that here on the cardiac cycle, where the black line, atrial pressure, is above the blue line, ventricular pressure. Blood rushes in from the atriums into the ventricles, increasing ventricular volume or the amount of blood in the ventricles. This is considered passive filling. Passive filling is when the heart does not contract the atriums to fill the ventricles. Blood is just flowing from the high pressure in the atriums into the ventricles without any force from the heart. It is passively flowing. The next segment of the cardiac cycle is diastasis, which is a continuation of passive filling from rapid inflow. As we can see, atrial pressure is still greater than ventricular pressure, keeping that mitral valve open. This will allow the ventricular volume or amount of blood in the ventricles to continue to increase before systole. Notice though in diastasis that one thing does change. The EKG picks up the P wave during diastasis. Remember, EKGs are just the electrical signals or impulses being sent to tell the heart to contract. It is not the actual contraction of the heart muscle. What does the P wave represent though? Atrial depolarization. This wave will lead us to the last part of diastole called atrial systole. Atrial systole is characterized by the atriums contracting to force more blood into the ventricles. Notice here how atrial pressure increases. This is achieved by Boyle's law, which states that as the volume or space decreases, or in other words, the heart contracts the atriums, the pressure will increase. This tops off the ventricles with more blood, increasing ventricular volume. Atrial systole is no longer considered passive filling, but active filling. We call it active filling because we are actively contracting the atriums to push more blood into the ventricles. This means that blood is not passively flowing into the ventricles, but is being forced into the ventricles by the atriums contracting. Notice during atrial systole on the EKG that we begin the QRS complex. This will begin the next segment of the cardiac cycle called isovolumic contraction. This is where we started at the beginning of the video. We have now successfully completed one cycle of the heart, or one heartbeat. Remember, this cycle we just talked about from the beginning to end occurs anywhere from 60 to 100 times in 1 minute in a normal individual. The last thing to note before we end the video are heart sounds. The sounds that we hear are normal and associated with valves closing. The first heart sound is caused by the mitral and tricuspid valves closing. We refer to this as lub. The second heart sound is caused by the semilunar aortic and pulmonary valves closing. This is dub, the second heart sound. The last and third heart sound is caused during rapid inflow. The blood is so turbulent when flowing into the ventricles that we can actually hear a swishing sound. Thank you so much for watching this video on the cardiac cycle.